very good morning to all of you. It's my privilege to join you online for this very important obesity management training program. A special thanks to Professor Nam and his team for the very kind invitation. In the course of my talk, I hope to be able to share some of the pharmacotherapeutic options with focus on the newer agents, and most importantly, the approach to the use of pharmacotherapy in the management of obesity as a chronic disease. These are my disclosures related to my presentation. What are the options that we have in obesity management? I present to you some of the FDA-approved medications that are commonly available around the world. Let's start with fentanyl. That's currently approved only for short-term use of about 12 weeks. It's actually been available for use since 1959. And prior to the approval of the currently newer agents, it was actually the most commonly used obesity medications, as well as most affordable. Thankfully, we now do have 6 medications approved by the FDA for chronic use of obesity management, or the chronic management of obesity. We can see that Orlistat has actually been approved since 1999, and it's actually currently available, I see, in Vietnam. I've grouped this into this group of metformin medications into the conventional. As you can see, between 2014 and then 2021 with the novel medications, there was really no other medications approved at the time. You can see that the indications for the initiation of these medications are pretty much related to the clinical trials which were done with these newer agents, which are with BMI 27 with 1 or 2 weight-related comorbidities or complications, or BMI 30 or more without any complications. However, we do know that there are many GLP-1 receptor agonists, such as exenatide, dulaglutide, oral and subcutaneous semaglutide, that have been approved for the use of type 2 diabetes. And because of their weight-lowering effects, people have been using it for also to lower weight in people with type 2 diabetes or even without. Now let's focus a little bit on the nutrient-stimulated hormones, or the NuSH, or commonly known as the gut hormones for obesity and metabolic treatment. These are the 5 hormones that are listed here, which have been the focus of a lot of medication or drug development in obesity. Let's look first at GLP-1. The GLP-1 was initially studied because of its glucose homeostatic effect, and then initially approved for type 2 diabetes because it can, in a glucose-dependent way, stimulate the production, the secretion of insulin, as well as to reduce the action of glucagon. But there are also appetite-suppressing effects centrally, and also at the moment we found that it's got cardioprotection. Now, because of its gastric emptying effects, it may sometimes cause nausea, but also centrally it may cause some nausea. Now, liraglutide 3.0 is the first GLP-1 receptor agonist approved for chronic weight management, not just in adults, but also in adolescents 12 years and above. For those who are not familiar, it is a daily subcutaneous injection initiated at 0.6 milligrams, titrated up weekly to a maximal dose of 3 milligrams daily as tolerated. Now, in the scaled RCTs of liraglutide, using up to 3 milligrams a day, you can see that whether it is in patients in obesity with prediabetes and patients with diabetes and sleep apnea, you can see a weight loss of about 8%. In completers, in some of the studies, this number can go even up to 9 to 10%. Now, in the maintenance trial, patients were put through the low-calorie diet and lifestyle intervention before being randomized to liraglutide or placebo, and those on liraglutide then got additional 6.2% weight loss. Clinically, in the real world, what we do is similar. We may put patients on very low-calorie diet or an intensive lifestyle intervention period, and after about 12 weeks or whatever time that we see the weight plateau, we sometimes then introduce obesity medications such as liraglutide. Now, the once-weekly GLP-1 receptor agonists have really revolutionized the treatment of overweight and obesity. The first was approved was once-weekly semaglutide in the form of Wegovy, 2.4 milligrams. On the right, you can see the flex pens that are in various doses, which we start at 0.25 with up titration every 4 weeks to a maximum dose of 2.4 milligrams. Now again, patients just inject this subcutaneously once a week. And in the STEP RCT trials, you can see that be it for patients with just obesity and whether combined with intensive behavioral therapy or in the step 2 in patients with type 2 diabetes, we can see for the completers weight loss of up to 18.2% can be seen. And in people with type 2 diabetes, in whom weight loss is generally lower compared to people without diabetes, weight loss of up to nearly 11% can be seen. But what's most significant is now we can see that about 3/4 of the patient on semaglutide 2.4 can lose at least 10% of their weight, with half of the patients, subjects being on 2.4, being able to achieve 15% or more of their weight loss. Now, when we add GIP to GLP-1, we see further appetite suppression, mostly from the enhancement of not just GLP-1, but also we see good lipogenesis effects and with GIP-1 and with tirzepatide, which is a single molecule with dual agonism of GLP-1 and GIP, in its SURMOUNT-1 trial of obesity, we can see that with tirzepatide 5 mg, which is the lowest dose, weight and mean weight loss of 16% can be seen at 72 weeks, with weight loss of up to 22.5% in this highest dose of 15 milligrams. Now, this is the quick pen of the various doses of tirzepatide, which starts at 2.5 milligrams, again injected once weekly subcutaneously and up titrated by 2.5 milligrams every 4 weeks as tolerated to a maximum of 15 mg. But again, you can see that now we can see 90% or more of patients being able to achieve at least 10% of their weight at 15 mg, and about with the 5 mg, about 73% of patients being able to achieve 10% or more weight loss, similar to semaglutide 2.4. But if you could move up the barrel, up the scale, you can see that now nearly 40% of patients can lose at least a quarter of their weight with the 15 milligrams. This is a study of the SURMOUNT, also included patients from Asia, which then can be relevant to us in terms of its weight loss effects. Now, tirzepatide is now currently only approved for people 18 years and above. Now, with further use and harnessing of with glucagon, one can see not just with decreased appetite, but there's also increased lipid oxidation, decreased hepatic lipid synthesis, and as we can see with mazdutide, which is now approved in China for the use of overweight and obesity, we can see weight loss of nearly 16% with 6 mg, this highest dose, but you can also see reduction in ALT as well as systolic blood pressure and TGs, which come very nicely there. There are also 2 other medications, which are glucagon dual co-agonists, and cordutide and survodutide, which are currently in phase 3 trials. In fact, survodutide has shown very significant effects on not just resolution of MASH, but also improve in liver fibrosis up to F3 stage, and it is currently still under phase 3 trials now. Now, I think we need to discuss the common side effects of semaglutide, and tirzepatide, them being gut hormones. You can see that nausea and especially diarrhea, vomiting, constipation, and GI side effects are very, very common, but it seems to be more common in semaglutide, and that is perhaps tirzepatide with its GIP agonism has a bit of anti-nausea effect there. But we do see patients complaining of irritation, such as burping or even GERD. To circumvent that, we advise patients to go very low-fat diet and also high-fiber diet. As you know, with increase in fat in the diet, that can also further reduce gastric emptying and then exacerbate the side effects of these medications. Now, a lot of patients will tend to experience it when we initiate the medication or when we up-titrate of each dose. So please do warn your patients in that. And I think even if patients experiencing the side effects, when they're expectant of it and know how to deal with it, they can then be able to tolerate it and ride their way through the titration of the medications. Of course, there are also other concerns such as acute pancreatitis, cholecystitis, or cholelithiasis, and also on concerns of patients with psychiatric disorders, only because people with active psychiatric disorders were excluded from many of the RCTs. There was also concerns about worsening of diabetes retinopathy and also this very rare MAION eye disorder. But actually, in the sub-analysis of many of the RCTs, these incidents were either not reported or were not increased. Now let's look a bit at the pipelines here. As you can see clearly that the pipelines for NUSH or gut hormone-based obesity therapy use GLP-1 mainly as the backbone, whether they add on GIP, glucagon, or even triple agonism, or in a single molecule, or they can then combine it with other gut hormones such as amylin and PYY. There's also a new class of medications being studied, which is the activin inhibitor, IV bimagrumab, which can be given every 4 weeks, combined with weekly semaglutide 2.4. Now, the beauty of these medications is that they are able to preserve muscle mass, and in the form of weight loss, then result mostly in fat mass loss. Now let's look a little bit of some of the trials that are in pipelines. This is semaglutide 7.2 in the step up. Compared to semaglutide 2.4, we can see additional weight loss with semaglutide 7.2 up to 20.7%. While the absolute weight loss may not seem a lot, you can see then the percentage of subjects who can achieve weight loss of more than 20 or more than 25% are much higher with the SEMA 7.2. In the very same way, oral semaglutide 25 milligrams in the OASIS 4 studies have also shown greater weight loss compatible with semaglutide 2.4. In fact, these two dosages or medications have been filed with the FDA for approval for obesity management. And if so, approved oral semaglutide will then be the first oral GLP-1 for obesity management. Now, orgliflozin is also an oral GLP-1 receptor agonist, but it is non-peptide based, and therefore we can circumvent the issues with absorption with the peptide-based ones with oral semaglutide. And at this maximum doses of 36 milligrams, you can see weight loss of 12.4%, and you can see that at least half of the subjects can lose at least 10% or more of their weight. Overall weight loss seems less than semaglutide 2.4, but the advantage of these medications is then with food absorption, it is better in relation to absorption and food intake. This may be even more advantageous and may potentially improve compliance when approved. It is currently also been filed for approval by the FDA for obesity management. Now, I think first of its kind, this is a triple agonist, GLP, GIP, and glucagon triple agonist, retatrutide. In this phase 2 trials, you can see at 48 weeks, you can achieve up to 24% weight loss. We know with the GLP-1 long-acting agents that some weight loss can still be seen up to even 52 and 72 weeks of use. So perhaps this is just the tip of the iceberg here, but what's most important, most striking, is that now you can see weight losses of more than 30% in at least a quarter of the subjects, and nearly 50% of subjects can achieve 25% weight loss. And an impact on triglycerides lowering and also systolic blood pressure lowering is very starking, and this is the contribution mostly from the glucagon receptor agonism, as has been discussed with the dual agonist of mazdutide. Now, in the cafraglutide or maritide for short, is actually a very unique GIP antibody with GLP peptide activation, and it can be administered once a month. In its phase 2 trial, you can see weight loss of up to 20% in patients with obesity at 52 weeks and 17% in patients with type 2 diabetes, with HbA1c lowering of down to 2.2%. Again, not just weight loss are great, but this is a once monthly administration, which can then therefore improve perhaps compliance down the road if approved. The phase 3 trials are still ongoing now. Now, amylin is a copeptide secreted with insulin, but it's also been found to have appetite suppressive effects centrally, and also it's able to increase energy expenditure. And in the first of its kind of cagrilintide with semaglutide administered once a week, we can see weight losses of up to nearly 23% after 52 weeks on this highest dose. And again, this is very similar to what we see with tirzepatide with this dual agonist here. So in the last few minutes, let's talk about how we can position the use of obesity medications. I think very traditionally, we've always used a one-size-fits-all, a BMI cutoff to decide on treatment, and then we give everyone a weight loss goal of about 5 to 10%. Now, I think we must not forget, as a chronic disease, obesity has its own pathophysiology, but most importantly, it can result in a whole host of health consequences that can impact the quality of life in our patients. And as with every chronic disease, we need to therefore then assess the risk of obesity on the health impact on the patient, and then use the goal of therapy to prevent or treat the complications, as we do with other chronic diseases like type 2 diabetes, hypertension, and cardiovascular disease. Many of us are internists and practitioners who treat type 2 diabetes, and when we treat type 2 diabetes, we use an A1C as a biomarker, but then we also tailor the HbA1c goal according to the patient profile, and the goal of it is to lower A1c is to prevent complications. At the same time, when complications are existing, such as CKD or retinopathy or cardiovascular disease, we want to lower the A1c to prevent the progression or the severity of these complications. And likewise, we should approach obesity treatment as a chronic disease in the very same way, using weight loss, the treatment of weight loss to prevent obesity-related complications. And when these are in existence, some of which are listed here, the target weight loss should then be to treat the underlying obesity-related complications. As you can see, the 5 to 10% may not necessarily cover all obesity-related complications. Therefore, in a patient who has MASH fibrosis, 5 to 10% of weight loss may not be sufficient to treat or resolve the MASH, even the hepatic fibrosis, which traditionally required 20% or more of weight loss. And with an established diabetes, obviously with just 3 to 5% of weight loss, that can improve the hyperglycemia. But if type 2 diabetes remission was to be desired, then greater amounts of weight loss will be required. Therefore, we need to set our target and then look at the efficacy of our various obesity interventions and use that to match the target weight loss that we need to treat the obesity-related complications or to prevent them. But again, we mustn't forget that GLP-1 receptor agonists have benefits that beyond weight loss, and particularly with anti-inflammation and on the cardiovascular system and even on metabolic liver disease. Besides having weight loss, we can see that in the SELECT trial, the use of semaglutide 2.4 in patients with established cardiovascular disease has benefits that are beyond weight loss. The benefits are seen within 6 months, and the weight loss, average weight loss at the end of the trial was only at 10%, suggesting that the relative risk reduction of 20% MACE goes beyond just weight reduction. There's also benefits in heart failure, in the STEP-HFpEF, in ME-OA, as well as liver improvement of MASH, as well as improvement of fibrosis in the ESSENCE trial. In the SURMOUNT trial with OSA, it's also been shown to improve the severity or even resolution of OSA, as well in the SUMMIT trial. Similarly, there's positive effects on heart failure with preserved EF. As such, the FDA has approved semaglutide for MACE reduction in those with established CVD and also in MASH with moderate to advanced liver fibrosis, as well as tirzepatide for the treatment of OSA with people with overweight and obesity. So I think there's now been a shift in paradigm to personalize our treatment targets based on a chronic disease model of care, not just to reduce weight, but also to improve physical function, to reduce the CVD risk, and ultimately to improve the quality of life for our patients. Now, with tirzepatide and the newer agents, we're going to see greater weight loss. However, the impact on things like CVD and NASH outcome studies have not been fully reported. So I think while weight loss is great, we do not know if the benefits in these obesity-related complications would really pan out. In closing, I think we need to consider that algorithms always say you do this, and if targets are not met, then we add on additional therapies. I need to bring on the point that all these therapies should be adjunctive and complementary and not exclusive of each other. And we should not use failure of treatment, but just to say that the targets are not met. And then as such, I want to highlight that the IFSO has even put a position statement that obesity medications can be used before bariatric surgery, for example, in patients with very high BMI in prep for the surgery, or even years after the surgery when there's weight regain, or even there's insufficient weight loss after surgery. Now, in individuals with very, very severe obesity-related complications, a very high BMI, as a very first line, we should even consider combining pharmacotherapy or bariatric surgery with lifestyle interventions. Again, we should not use a cookie-cutter approach, but to say we are treating the patient as a whole, our assessment of risk and treatment in an adjunctive and complementary fashion. So in conclusion, I've covered the various types of obesity medications with focus of the newer medications and also the pipeline medications available with GLP as the backbone. But last but not least, I think we must not forget it's the patient at the heart of our treatment. We must consider the patient cues, their preference, and again, with the affordability of the medications so as to enhance the compliance and adherence to these medications, and ultimately to improve the quality of life and health outcomes for patients living with obesity. With that, I thank you for your attention. I apologize for being late.
Thank you very much for very comprehensive review. Vậy như vậy là tôi nghĩ là cuối năm, đây là hội nghị cuối năm mà chúng ta được cập nhật rất là nhiều thứ và nhiều bằng chứng liên quan đến lĩnh vực điều trị về giảm cân và béo phì này. Và sau đây thì đến phần thảo luận thì các bác sĩ mình có thể có những cái câu hỏi, mình có thể đứng lên mình hỏi trực tiếp hoặc là gửi cái câu hỏi lên để chúng tôi có thể hỏi các speaker. Đặc biệt là chúng ta sẽ dành câu hỏi cho hai báo cáo viên nước ngoài là giáo sư Brian và bác sĩ Kwang-Wei. Xin mời bác sĩ Lâm mà cũng liên quan đến phì nhiều á, phẫu thuật á.
Cái nãy cái slide này cuối cùng mình thấy không, đó là combination nè. Thành thử là cái điều trị thì béo phì nó bà tôi mới nói chuyện với bác sĩ Khải giống như thuốc ung thư vậy thấy không, và điều trị béo phì thì điều ung thư cũng giống nhau.